Chairman, ladies and gentlemen, thank you very much to the ASGBI. It's a pleasure to come and talk in the BJS section, as indeed it was a pleasure to read this tome here, which was Thyrotoxicosis in the Surgeon, a critical review by Victor Riddell, I think. It's pronounced, a man I didn't meet, but a distinguished surgeon with a particular specialty in thyroid surgery at St. George's Hospital when it was still SW1. It was a pleasure also to read it because the standard of the English writing in this document was quite superb. The editors were clearly less draconian than they are these days, as he was allowed to stray into philosophy, into Greek mythology, as well as sticking to the facts. This was a 35-page article, and it was only after 22 pages of basic science that we actually got on to anything surgical. And that may be a reflection of the changing value, if you like, of the British Journal of Surgery over the years, and perhaps also a change in the competition for publication in this distinguished journal. So, when it comes to the facts, at the time there was no infallible test of thyroid function. And in fact, the clinicians of the day had to immerse themselves into some really significant basic scientific work. They looked at radioiodine total body uptake. They looked at plasma protein bound iodine, which was a very difficult study to undertake, measurement to undertake, urinary excretion of radioactive iodine, measurement of the basal metabolic rate, which that took 3 pages to define, and measurement of plasma cholesterol. And just a glance at this very busy slide, but I photographed it from the paper, shows that it was really quite difficult to label patients as to whether they were truly euthyroid, hyperthyroid, or myxodematous. There was quite a lot of ignorance at that time. Back in 1835, in Dublin, Robert Graves described the affectation in women of what we now know as Graves' thyrotoxicosis. In fact, Graves thought it was, an underlying cardiac primary pathology, and not a lot more was known about it in 1962. And so we're very privileged today to have the specific radioimmunoassays to measure free T4, free T3, measure TSH. It is easy for us. We are far less scientific as surgical practitioners than those of our colleagues 40, 50 years ago. Immunology really got a grip in medicine in the late 70s, and now we have a pretty comprehensive understanding of the autoimmune diseases of Graves and Hashimoto's. But every now and again, we still do the same scans that they did in the 60s, the CT scan. The other thing that was unknown at that time was the danger or safety of, in long term, of using radiation. And radiation is a very good treatment we regard now for Graves' disease, as was then. And so it was the practice for this fear of the effects of radiation to limit it to patients over the age of 45. And in fact, we're still not that secure. Our confidence was rocked a bit following the Chernobyl explosion. It maybe rocked a bit more with recent events in Japan. And in fact, exclusion of using radioiodine in people under the age of 45 has actually inhibited our ability to predict. And so we still are not truly certain about radioiodine and safety in children. Now, Mr. Riddell talks about hovering, the surgeon having to hover between the scilla of organic disease versus the Charybdis of functional disease, and I had to look that up. One's a serpent and one's a whirlpool. But basically, it's possible that many patients who were thought to have thyrotoxicosis in those days may actually have been of a nervous disposition. But it's particularly nice, I think, that we see a very humane and very kind attitude from a general surgeon in the 1960s towards that, noticing that sympathetic handling and a little bit of convalescence and rest in bed may actually be the solutions. In consent about the voice, if the patient is very nervous or toxic, it may be kinder not to refer to the matter. Now, I'm sure that legal bodies now and patient advocate groups would consider this attitude to be slightly patronizing, if not pompous. But having done a clinic yesterday where I put the fear of God into 5 patients about the potential risks to their voice when the risks are very small, one wonders actually whether the pendulum has swung a little bit too far. If they read this, the operation sets the patient on the right road to recovery, but to consolidate the advantage gained, a proper period of convalescence should be insisted on. And when we talk now about day of surgery admission, reducing average length of stay, day case surgery, we sometimes forget that the operation is but one event in the patient's journey to recovery, and one perhaps should be thinking more about the convalescent period. Now, in terms of fashion, patient preference, because we have a choice, particularly in patients with Graves' disease, whether to operate or to give radioactive iodine. And if a patient has formed an antagonism to one modality of treatment, it's not unreasonable to allow them to go in another direction. And this has not changed. In Per Hellman's paper not very long ago, underscoring the importance that we have a duty to describe all options to patients in an unbiased way and to allow them to make a decision, and we shouldn't go against their wishes. The big thing in terms of surgical practice at that time, and actually up until the mid-80s, was whether to perform a subtotal thyroidectomy or a different operation. And that the surgeon should determine how much gland to remove, because they regarded then, as we do now, that recurrent thyrotoxicosis is not a complication, it's a disaster. And I think we can be much clearer now that the gold standard operation, as in Lee Delbridge's paper here, is a total thyroidectomy. So we think we've perhaps moved on there. But one must congratulate Mr. Riddell for his foresight. It is only a matter of time before certain operations become obsolete. And the 2 procedures spring to mind: removal by partial gastrectomy of a large portion of normal stomach in the treatment of a duodenal ulcer, and the operation of subtotal thyroidectomy in the treatment of hyperthyroidism. Now, it was a subject of debate, and should not be anymore, as to whether one should be routinely identifying the recurrent laryngeal nerve at the time of thyroid surgery. And his view here was that it was a good thing, a good discipline in training surgeons, whereas now I think it's pretty much regarded as a standard that all nerves should be identified prior to resection of thyroid tissue, although it was a bit woolly in the overall woolly NICE guidelines when they looked at intraoperative nerve monitoring. Bleeding in 1962 clearly was a big issue in thyroid surgery, and there's long accounts and paragraphs containing words like horrendous. And so there was a keenness to minimize hemorrhage, and a lateral ligation of the inferior thyroid artery was judged then to be the best way forward. Of course, now we have modern methods of hemostasis, either with just simple good surgical technique, anesthesia, as well as modern diathermy and other things. And now we recognize that we should be doing peripheral ligation as far down the branch of the inferior thyroid arteries as we can to preserve the blood supply to the parathyroid glands. Now, the interesting thing about complication rates is that the obsessions that we have not changed in 40 years. And if I show you just a snapshot of two results from the national audit of the British Association of Endocrine and Thyroid Surgeons, whilst this is almost certainly underreported because we're not looking carefully enough with laryngoscopy, it's 1.3%, but Mr. Riddell should be congratulated at his time for being so modern in recording his outcomes, and he was running at a higher percent. And with the other complication of permanent hypoparathyroidism, which was much more difficult to measure and diagnose back in the 60s, we seem to be getting better, probably because of less hemorrhage and better view and maybe greater attention to detail. So, Mr. Chairman, ladies and gentlemen, some things have changed in 1962, some things haven't. This photograph was taken in March 1962, the same time as this paper was published. What has changed is that I'm now slightly taller than my sister. What hasn't changed is the follicle count on my scalp.